Hello everyone, hope all of you are doing great. Welcome to this section on diagnosing the anaphylactic shock and understanding the role of laboratory testing after stabilization of the patient. So quick and accurate diagnosis is very crucial, especially in emergency settings. We will be reviewing the high-yield criteria for the bedside recognition of the anaphylaxis and look at how serum tryptase and specific IgE testing help confirm and understand the episode of the anaphylaxis. FAAM and the World Allergy Organization have set practical criteria to help clinicians diagnose anaphylaxis quickly. If any one of these three criteria are met, anaphylaxis should be strongly suspected. This ensures that we don't delay the treatment while waiting for the lab confirmation. At the bedside, be vigilant for the rapid onset of the skin signs, the airway symptoms, or the cardiovascular collapse, especially after exposure to a known or suspected allergen. Anaphylaxis is a clinical diagnosis, and you don't have to wait for the labs to treat the patient who might be suffering from the anaphylactic shock. Serum tryptase level peak 1 to 2 hours after the onset of the symptoms and can help retrospectively to confirm the anaphylaxis. What do you mean by retrospectively confirming if there was anaphylaxis or not? For example, you suspect a patient who already might be suffering from the anaphylactic shock after the allergen exposure. Now, you don't have to wait for the lab results or the tryptase levels to be raised in order to confirm the diagnosis of the anaphylaxis. If there are three symptoms, if the skin is involved, if there is airway compromise, and if the patient is showing the cardiovascular symptoms of the anaphylactic shock, you will proceed with the treatment first, and then you can later on confirm if your diagnosis was correct or not by sending the labs for the tryptase levels. So it is especially useful in unclear or biphasic cases, but you have to remember that it's not always elevated in all the cases of the anaphylactic shock, particularly those anaphylactic shocks which are preceded after the allergen that's related to the food, or the food triggered reactions do not raise the tryptase levels. That's not always true. Now, once you have recognized the case as the case of anaphylactic shock, you have given the initial treatment and you have also confirmed it by sending the tryptase levels, and the patient is stable, we can pursue the allergen specific IgE testing to pinpoint the trigger of the anaphylactic shock. So, this is done days to weeks later after the exposure of the allergen and supports the clinical suspicion. It is an important part of a long-term management and the prevention of the future episodes of the anaphylactic shock. To wrap it up, remember anaphylaxis is a clinical diagnosis and you have to act very fast in these cases. Use the structured criteria, but when in doubt, you have to treat the patient always. You have to treat the patient first. You have to treat them at your top priority. Serum tryptase and the specific IgE are great tools after the stabilization of the patient. I repeat, you have to check the tryptase level and you want to do the IgE testing. That would be done once the patient is stabilized. First, you have to move to treat the patient, especially when you need to confirm or clarify the cause. Let's now move into the emergency management of the anaphylactic shock.